My name is Alan Weil. I'm Editor-in-Chief of Health Affairs. We're very pleased this morning to be hosting this session entitled Understanding the Value of Innovations in Medicine. It's an exciting and important topic, and you are, I am sure, at the end of the morning going to understand the nuance and complexity of this issue far more than you do at the moment because of who we've gathered today to talk about this. I want to acknowledge the support of the Innovation and Value Initiative for making the event possible. Let me set the stage just for a moment as we get started. It is commonplace in healthcare today to say that we need to move from volume to value. It's hard to be against paying for value instead of just volume. But beyond those general terms lies a tremendous amount of complexity. And it's some of that complexity that we hope to uncover today so that those in the policy community, which is the audience we strive to reach, can move beyond the rhetoric and think more practically about what it will take to move our healthcare sector more in the direction of paying for value and outcomes and less in the direction that it is now of paying primarily for pills or activities or events, procedures. Of course, value is a complex concept, and you will hear much more about it in the first panel. If we're going to pay for value, there are essentially at least two things we have to do, and what we've tried to do today is divide the conversation somewhat along those lines, although it's more complex than this. The first is to understand what value is. What does it mean? How do you think about value? The commonplace conception of value is quality over price. The more you get, or the better outcome you get for the less money, it's more valuable. But it turns out that even that is dramatically oversimplified. How do you measure quality? Whose quality? Whose price? What is price? Who's paying for value? Who's receiving the value? Those are some of the concepts that we'll be discussing in the first panel this morning. And of course, different aspects of healthcare look at and treat and think about value in somewhat different ways. So we talk about value-based payment models in hospital care and physician care, and we talk about value contracting in the biopharmaceutical area. And the way that those areas and thinking about value have emerged and grown is not the same, and some of those differences will also be apparent this morning. But even if we had a clear sense of what quality is or what value is, there's still the question of what do you do about that? And that's what the second panel is going to talk about. Where do we go with this concept of value-based reimbursement? As I have probably said at this lectern before, the challenge with paying for value is that if value is quality divided by price and you pay more for value, by definition, you're reducing the value. In other words, if you increase the denominator, the price, the value has gone down. So if you pay for value, you reduce value. That can't be what we want to do. What we want to do is encourage value. We want to reward value. We want to have those in the healthcare sector think about what value they're providing, and as will be discussed today, we want to think about the relationship between price and payment and what the value of a procedure or a pharmaceutical might be. So the question of how you take concept of value and move them into the real world will be the topic for our second panel. So that's the order of the day. As I say, these are complex issues. Our goal is to bring to a policy audience an understanding of the nuance, an understanding of the importance. As we hear people say that we are moving our healthcare system more to paying for value, I think it's important to understand what it means, and it's also important to understand what it takes. And that's our goal for today. So this morning, the first session will be moderated by Sam Nussbaum. Sam Nussbaum is a senior fellow at the Schaefer Center for Health Policy and Economics at the University of Southern California, a strategic consultant with EBG Advisors, Inc., and a chair, where I've seen him present admirably, of the panel of health advisors for the Innovation and Value Initiative. He was the Executive Vice President and Chief Medical Officer of Anthem, where he oversaw medical and pharmacy policy, health improvement, care management, provider contracting, payment models, and outcomes research. That's the role he was in when I met him. He's been a professor at Harvard Medical School and led basic and clinical research at Massachusetts General Hospital. So I'm going to invite Sam up to kick us off, and I'll ask the panelists for the first panel to join him as I hand the microphone over to Sam.
Good morning, everyone, and Alan, thank you for that kind introduction, but more importantly, the introduction to the topic, which is so pressing for all of us. You know, it's very much like the opening of A Tale of Two Cities. We live in the best of times and the worst of times. The best in times because of breathtaking science and discovery and innovation and cures and molecular knowledge and gene therapy and other approaches on the horizon. Yet, healthcare costs are certainly crowding out investments in infrastructure, in education, housing, the social determinants of health. So this is really the sort of overarching consideration for our dialogue today, that of value in healthcare. Drugs account on the commercial side for about 20 to 25% of all healthcare spending. Let me repeat that because I think that is not always well understood. 20 to 25% of commercial spending. And if you account for Medicare Part B specialty drugs, it's probably in the mid-teens and growing. And there's a global set of issues related here too, because when you think of this, US purchases almost half of the world's drugs, and the profits generated for discovery and for global pharmaceutical companies, the majority come from the US. And as Alan said, that there has been a tremendous emphasis on value in the rest of the US healthcare system. In fact, several years ago, the bold commitment to move CMS payments to value 30% by 2016, 50% by 2018, and the private sector has joined CMS in working toward that goal. Yet payment for drugs appears to be stuck in a 20th century construct that focuses on price regardless of health outcomes. And when you think of that, this lack of innovation, which the second panel is going to certainly talk about, and the foundation for our discussion, the first panel, is particularly damaging in an era where we have new treatments and cures and personalized medicine. So this is really the challenge that we have. We know that total economic value for treatments, and I thought it'd be fascinating to go back and look 50 years ago. Coronary artery death rates have declined by almost 70%, 70%. And I think we can say, yes, some of that is the technology of cardiac interventions from bypass surgery and percutaneous interventions, but a good part of that is the reduction of cholesterol by statins. So how do we take those concepts with the fact that HIV/AIDS is now a chronic illness, thinking about the future of Alzheimer's and cancer, and how do we take those concepts and really build the models that will have the profound impact that we want? So when we think of models, and that's what the panel, who I'll introduce in a few moments, will focus on, we have talked about qualities, and you'll hear a lot about that, but there are other issues. If you're an employer, workforce productivity is paramount. Caregiver burden, if we were considering approaches to Alzheimer's disease. Public health perspectives, when we think of a cure for hepatitis C. And then we think of concepts like option value, allowing people to have their lives sustained while new treatments emerge so that we can invest in these innovative gene therapies and RNA and therapies and CAR T therapies. So we have a lot of issues that we should be discussing. There are new organizations. The US doesn't have a national organization for health technology assessment, and ISPOR, a leader in this arena, is being joined by new organizations such as IVI, professional organizations such as the American College of Cardiology and ASCO and NCCN, and advocacy and patient groups, and we'll hear about that today, are taking advantage of these types of assessments. So these are the issues that are essential that we're going to address today. And let me introduce the distinguished panel that will each individual will speak for about 7 minutes or so. And then I will follow that up with some moderated questions. But most importantly, we want your engagement in this dialogue. So let me introduce the panel. This is the order they will be speaking. Lou Garrison is Professor Emeritus in the Pharmaceutical Outcomes Research and Policy Program in the School of Pharmacy at the University of Washington in Seattle. He has been at University of Washington since 2004. As a leading health economist, he's worked in a diverse variety of settings, including Health Affairs Project Hope, pharmaceutical industry for Roche, and in academia. Lou is immediate past president of ISPOR, the International Society for Pharmacoeconomic and Outcomes Research, and actually, along with Peter Neumann, who you're going to meet in the second panel, is co-chair of the ISPOR Special Task Force on Value Frameworks. Rena Conti is Associate Professor of Health Policy and Economics at the University of Chicago in the Departments of Pediatric and Public Health Science. Her research applies economic methods to analyze incentives driving prescription drug development and adoption. She has focused on specialty drugs because, as we've said, this is the epicenter of this key policy issue that we're dealing with, this trade-off of providing incentives for innovative activity versus success and affordability, access and affordability. She currently serves as a member of the National Academy of Medicine, Engineering, and Science Study on Prescription Drug Access and Affordability. Darius Lakdawalla holds the Quintiles Chair in Pharmaceutical Development and Regulatory Innovation at USC, where he's on the faculty of Schools of Pharmacy, the Saul Price School of Public Health, and the Leonard Schaefer Center for Health Policy and Economics. Darius is a research associate at the National Bureau of Economic Research. In addition, he is a co-founder and chief scientific officer of the healthcare consultancy organization Precision Health Economics, and serves as executive director of the Innovation Value Initiative, which is a collaborative of diverse stakeholders dedicated to improving the way that value is measured and rewarded. Jeroen Jansen is chief scientist for evidence synthesis and decision modeling at Precision Health Economics. He's trained as an epidemiologist at Erasmus University in the Netherlands, has a 15-year history of research in context of health technology. He lectures on evidence synthesis at Stanford and is co-author of a soon-to-be, it sounds like, Jeroen, this is like your book tour, huh? This is a soon-to-be textbook on network meta-analysis for decision-making. I'm sure that the exciting as this is published soon by Weil, and most recently, he's overseen the development of open-source cost-effectiveness models of the Innovation Value Initiative and is really a thought leader in this domain. And most significantly, Anna Hyde is the Vice President for Advocacy and Access at the Arthritis Foundation. She oversees federal and state legislative programs in addition to grassroots engagement. She was Senior Director of Advocacy and Access, managing the federal affairs portfolio and overseeing the state advocacy team previously. And then before that, before joining the Arthritis Foundation, she worked as a senior manager for federal affairs at ACOG, the American Congress College of Obstetrics and Gynecology. She began her health policy career as a congressional fellow in the U.S. House Energy and Commerce Committee, so is also comfortable and familiar with Washington. So let's begin, Lou, with your presentation, and thank you all for being here.
Okay, not having any luck advancing that. So. Okay. Okay, got it. I'm sorry, it's a little bit slower than I thought. Okay, I'm a little slower. Maybe that's the problem. But anyway, good morning. Thank you, Sam, and thanks to Health Affairs for the invitation. It's really a great opportunity and a pleasure to participate in this discussion and kick off this discussion. I want to make sure I stay close to my 7 minutes. So, what I'd like to do is provide some background a brief high-level overview of ISPOR's Special Task Force on U.S. Value Frameworks, and ending with a presentation of our latest evolving recommendations. 18 months ago, ISPOR convened a special task force to examine the plethora of recently promulgated value frameworks that had come into the U.S. healthcare sector. Much of their focus was on medicines, new medicines, and their prices. However, there were obvious inconsistencies and concerns about the varying methodologies among the frameworks that seemed to be creating confusion among potential users. We wanted to take a look at the frameworks from a scientific perspective, and we aimed to review, so our aim was to review the relevant frameworks and discuss appropriate approaches and methods to support the construction and use of high-quality healthcare value frameworks that would lead to more efficient health resource utilization. So to do this, we initiated a multi-stakeholder approach that has been driven by a special task force of 13 expert health economists from the US and UK. Our results have been, and work plans and results have been reviewed at several stages, still under review by a range of stakeholders, including other experts, representatives of patient groups, industry, payers, and indeed we circulated the report to the entire ISPOR membership. The 5 frameworks, and Sam mentioned some of these, are on the slide. I'll say a bit more about them in a second, but we did review these five frameworks, recognizing that there are already a lot of other frameworks out there, both in other countries and previously in the U.S. And even last year, Peter's second panel on cost effectiveness in health and medicine released their report. So we certainly recognize that and talk about those in our report. Now, these 5 entities and their frameworks differ in their mission, scope, and activities and methodological approaches. But I'll say a bit more about them, but first I want to say a bit about seems like it's slower again, I'm not sure. Okay, good. I don't know if you can read that. So I want to say a bit more about what is value, and really from an economic perspective, a health economist perspective. So value can be thought of in several different ways, but from a health economics perspective, simplest thing to think about is what would someone be willing to pay for something. Now, one way you pay for things is to give up something else, so that's opportunity cost. And so if you've ever taken an economics course, you've run across those concepts. Obviously, value varies across individuals and over time. We get more information about how technologies work and so on. It's very difficult to measure in healthcare because of the way we're behind the veil of insurance. We don't have market transactions. Now, in principle, what we would like to do from a health economist perspective is ask a plan member, what would you be willing to pay in an incremental insurance premium to cover the inclusion of a new medicine or a new technology in the health plan? In practice, those impacts are so small that we can't ask that question to get a reliable estimate. So the whole methodology that we've developed around the cost per quality and so on that I'll talk about, I see as a pragmatic workaround to really, because we can't ask that question, we approach it from another way. But it's always important to remember there's no one value that sort of exists for everybody in all situations. It really varies across people and across health plans and so on. Now, our working premise here is it's critical to investigate these value frameworks because of the signals they send to innovators. So, value-based approaches can encourage firms to produce more of what we value. So that's really the motivation for this. Now, again, I'm sorry, I apologize for this slide, and you can get it in our report, but this slide tries to make the important point that these frameworks differ in terms of the types of decisions being made, what we call decision context. At the highest level is the health plan decision about whether to include a technology in the health benefit package and at what price. So this is the technology adoption decision that we hear so much about in health technology assessment. It's where most of the cost effectiveness analyses and other analyses, economic evaluations that economists do focus on that question. Peter Newman's database has thousands of these kinds of studies. Now, the 2 frameworks most relevant to this level of decision making are the ISPOR framework, which uses the cost per quality, and the Memorial Sloan Kettering framework, which uses drug abacus, which uses as a vector of attributes. Now, those are the 2. Now, in the middle level, you can think of benefit management and utilization management. And here, again, Sam mentioned the cardiologist and heart association. They advocated the use of cost effectiveness analysis in developing treatment guidelines, and that's kind of intermediate. It then sort of has aligns with then you sort of can go to the lowest level, which is the The physician, this interaction between the patient and the physician, which is what ASCO is dealing with. How should that dialogue take place? What should be discussed between those two? So the frameworks differ, but you could imagine that ideally they would be aligned so that they're supporting the same decisions. Now, you will see in a moment when I present our draft recommendations that we begin with the foundation of cost effectiveness analysis using the cost per quality metric. It's also called cost utility analysis. Okay. Now, this is what we call our value flower. It's shown in this figure. I'll have to describe the bubbles to you. The two green bubbles basically include the quality adjusted life year, which is a combination of mortality and morbidity, and the costs. And that's, but quality, as you called it, or outcomes over cost is value in the narrow sense. Now, what we're trying to say here is that there are actually a lot of other things that people do take into consideration, and they should take into consideration. For example, productivity and adherence are in the lighter blue, but the darker blue are a whole set of things that are really related to uncertainty and risk in medicine, which we know is highly prevalent. And I don't have time to go through each of those, but both Darius and Rena will be talking about some of these kinds of elements. But they're related to this uncertainty, and the thing is, as implemented in practice, the cost per quality does not take into account the fact that, for example, the peace of mind that people get from knowing that they're protected against catastrophic financial loss or catastrophic health risk is not in the quality. It's a different, it's there, so that's what Darius has named insurance value. He'll say more about that, but that's an important aspect. And it really is a differentiation of the U.S. healthcare system from the way that the Brits think about their healthcare system. But there are other factors you need to take account of, like equity, health equity, equity of access. And I can't go through all of these now, but it's in our report, and option value is mentioned, and value of hope. But I do want to talk about scientific spillovers, because I think we don't appreciate that, when we focus on the quality in the individual patient, we don't take account of the fact that there are knowledge externalities, that what any company does if they're working in a disease area and their product succeeds or their product fails, everyone else working in that space benefits from that. There's a spillover of knowledge. And if you just pay for the quality, you wouldn't necessarily be putting enough money in the pot to sort of encourage those spillovers. So our report talks about two ways of potentially integrating these factors. One we call augmented cost effectiveness analysis. So it would essentially be, putting valuations on these other petals of the flower. The other is multi-criteria decision analysis, which is often done in a group setting as part of a deliberative process, where a group process can put weights on these attributes to reach a group decision. And we're open to both of those and see that that more work needs to be done and more research on both of them. So let me quickly run through our in-progress recommendations. Our first recommendation is that these value frameworks and those who are using them need to be clear about the decision context. And what is it about the health plan adoption? Is it about the patient treatment guidelines, or is it about this interaction between the patient and the doctor? The second recommendation is that when it comes to coverage and reimbursement decisions, that high level, that health plans would be well served to compare the costs and benefits of interventions, in many cases, not necessarily all cases, by relying on the standard cost per quality, or at least beginning with that. That would provide for greater transparency and consistency of decision making. Third recommendation is that the cost per quality metric is not the end of the story, that we need to consider in individual cases whether these other important elements that I've laid out need to be brought into play. And so augmented CEA and MCDA can provide that broader perspective. Fourth, to operationalize these in health plan decision making, it's necessary to compare them to a value threshold. A value threshold, which might be a range. There's not one fixed threshold for all decision makers, for all patients, for all health plans. So, or even and that threshold could vary by diseases. So, but this idea of needing a threshold in combination with the other measures is important. The fifth recommendation concerns affordability, a concept that's recently received a lot of attention. because of the, in relation to the cure for hepatitis C, which would be costly from a societal level. We do not recommend a specific mathematical formula for this on affordability. Rather, the issue needs to be managed on a case-by-case basis by considering things like eliminating the use of existing technologies, staging the implementation, and comparing the cost effectiveness across new and existing technologies. 6, we want more research on the use of these technologies, particularly MCDA, in a structured deliberative process. Finally, we need to assess the frameworks in terms of consistency, reliability, and fairness. No single value assessment framework can easily accommodate both the health plan and the patient level, but well-designed patient-level frameworks can help to guide individual treatment decisions. So let me stop there. Our draft report is available on our website. I'm sorry I don't have time to read the members of the task force, but thank you for your attention. I look forward to the discussion. Thank you, Sam. Sorry I went on over 7 minutes. So.
No, thank you, Lou, for this important work that you've led in crafting a new framework and looking at what exists. And we'll talk about, the theme of quality and how did these more innovative or novel part of the framework get established later. Rena.
Thank you. Good morning. Okay. We stand in the midst of incredible scientific breakthroughs in biology. There are over 7,000 new drugs in development currently, and some, like Humira, are true cures. There will be others as well. In an article that I published in Health Affairs last year with some colleagues, we suggested that, like all breakthrough therapies, these treatments really have 3 components of value. There's the intrinsic value, which is what Lou was really focusing on, the benefits relative to the cost of these therapies that they offer to patients and to society, including potential externalities or spillover benefits that they provide to other people, including other patients, but also other members of people's families. There's also the option value of these therapies. In other words, the benefits created when a drug development occurs and spills over into the development of new and better therapies over time. I think the heart therapies for HIV are a great example of that. And then there's the intangible value of these therapies, which include the benefits of medical research in and of itself. In other words, the value of a hope that Darius is going to spend a little bit more time about. Value assessment methods that we typically think of, cost effectiveness measures or comparative effectiveness measures that we are going to be discussing all morning, should be really understood as an attempt to isolate and quantify the first element, the intrinsic value of this therapy. But their existence, these assessments, no matter how well they are done, is a necessary but not sufficient condition to ensure access to breakthrough therapies over time. I think we would all agree that that's actually the point of this incredible endeavor. Why? Well, from the manufacturer's perspective, the intrinsic value of the drug does not necessarily determine its price. Rather, these companies pursue pricing related to the temporary guarantee of monopoly rights that we provide in our patent system. It is an empirical economic question whether and to what extent the intrinsic value, this first component of these therapies, really determines its launch price. And on this, actually, the empirical evidence is actually quite mixed. In work that I published with my colleague David Howard, we looked at 58 new cancer therapies launched in the past 20 years. And what we found is that only approximately 1/5 of a cancer drug's launch price is related to its absolute or even incremental value as measured by a quality or measured by alternative metrics of this intrinsic value measure. Indicators of option value and also of this intangible value also appear to be important elements of the launch price. Yet we found the single largest determinant of the launch prices today are the launch prices of the therapies in the past year and the year before that. In other words, value isn't the only determinant of price of the drugs in the US market, rather the chutzpah of the monopolist matters too. Please advance. Nope. Oops. Okay. From the payer's perspective, value assessments may help determine access, but only up to a point. Currently, there are prohibitions on the use of cost-effectiveness and comparative effectiveness analysis for the public programs. And I would argue for truly novel breakthrough therapies in the specialty space, such as the new gene therapy Chimera, but other therapies to treat dead disease and cancer, that prohibition really matters. Essentially, payers cannot say no, nor can they truly restrict access to patients who have indications that are reflected in the label. For oral drugs and for commercial payers, we know that these assessments may help in terms of assessing formulary placement, negotiating better rebates and discounts on the launch price of the drug or its list price. It can also tame physicians' enthusiasm for using them in uncertain areas of medicine. But fundamentally, this doesn't alter the out-of-pocket costs that patients face for their use. And here's where the rubber really hits the road. What we really haven't figured out yet is the utility of the assessments when the evidence is clear that a novel drug is safe and effective. The launch price is predicated on the monopoly incentives I've already mentioned, and conveniently, the therapy is deemed cost-effective at traditional cost per quality thresholds. For example, the new drugs to treat hepatitis C are an obvious advance. They're virtual cures. The $85,000 per course of treatment to cure price, its list price, lightly reflects all of the components of value of a breakthrough drug I've mentioned, including that chutzpah component. And yet, payers working with fixed budgets, most notably state Medicaid agencies and the prison systems, have not been able to find the funds to provide access to these cost-effective therapies to their population, resulting in a major public health crisis. In 2014, less than 3% of patients with hepatitis C insured by state Medicaid agencies were able to get access to this therapy. Now, so here's our challenge. Acting on recommendations from the National Academy of Medicine, myself, my colleagues from MIT, and also from Johns Hopkins have been working to assess whether we can use elements of the value-based assessment to look for opportunities for the state of Louisiana and a handful of other states to actually provide access to their state Medicaid population for this therapy. What we've run into is a couple of roadblocks, let's say. First, CMS rules require formulary coverage by Medicaid agencies. Secondly, although we may be able to leverage these value assessments to obtain better prices, that will only work up to a point. Lastly, the assessments as they exist now don't really reflect the problems that we are facing for gaining access. Most notably, the cost assessment of who accrues what, for example, doesn't necessarily accrue to the state. For example, transplant costs are an obvious cost savings from an individual perspective and from a society's perspective. However, from the state's perspective, if you avert a transplant in one patient, that doesn't necessarily mean that you avert the cost of the transplant in another patient that you are also responsible for caring for in that given period. Secondly, costs and benefits to whom relative to what? A state budget is fixed. They have annual budgetary requirements. And so the costs averted and the benefits associated with averting cirrhotic liver, those have to be weighed in relationship to the benefits and costs of investing in roads, schools, poverty programs, substance abuse programs, et cetera, that the state is also on the hook for. And then finally, These assessments must be done in a timely manner that reflects the new innovations that are coming through, also reflects the populations that the state needs to cover, and finally needs to be updated in real time to reflect specific issues that, that come up with these populations and that get information that gets revealed over time. Therefore, the use of these metrics really as they exist now may not actually help us think about, okay, what exactly should be the price that we should be charging or we should be willing to pay for these therapies if we just wanted to focus on the intrinsic value. Most concerning, if we want to just use these assessments to base a ceiling price for what the state would be willing to pay for the intrinsic value of these therapies, we run headlong into this challenge of paying for innovation. In other words, we say, okay, we just want to pay for intrinsic value for our specific population, and in exchange, we'll give you guarantees for quality, and what we get back is, oh, you're blowing the incentives for innovation. What about all of them? What about all of the value of option value, intangible value, et cetera? Shouldn't we get reimbursed for that as well? So I do not believe that these challenges are insurmountable. I think we have a lot of tools that we can use to trade off payment for this intrinsic value relative to payment for pulling more innovations into the pipeline. But these are challenges that we're going to need to address in the future to make these assessments actionable. Thank you.
Thank you, Rena. I think you can see the trade-off of public health for Sovaldi hepatitis C and affordability and cost in Rena's comments. More to be discussed later on that.
Thanks, Sam.
Darius.
Thank you very much, Sam. Thanks to Alan and Health Affairs for having me. It's a real pleasure to be on such a distinguished panel. I want to build on what Sam, Lou, and Rena have all talked about, and let's kind of back up to the reason we're here. And the issues are, first of all, we need to make sure we get the assessment of value right. Why? Well, so then ultimately, as Rena pointed out, we need to link value assessments to pricing, and that's not currently done effectively. And the reason we want to do that is because prices that are linked to value encourage the right kinds of innovation. They encourage valuable innovations, and they discourage less valuable innovations. So now, what I want to focus on is the question of how we improve, advance, and innovate in the assessment of value. So let me begin with, I got to time this. I haven't ever been skeet shooting, but I imagine it's a skill that would be helpful here to figure out when to hit the button. But let's see. Okay, so the value from an economist standpoint, value means the willingness to pay for those who are responsible for paying. So if you think about this from the perspective of how we measure it, we generally think about a new drug that comes in and maybe it's more valuable than an existing product. And the question is, how much is a patient willing to pay in order to retain access to the new drug versus the old drug? Now, the question becomes immediate. Well, it's the willingness to pay, but of whom? Sam mentioned this, Lou mentioned this as well. Ultimately, in healthcare, the payers are patients and plan enrollees and or taxpayers when you're dealing with public health insurance schemes. So the question that we really want to understand the answer to is, what the heck is the willingness to pay of patients who are laying out their hard-earned out-of-pocket dollars, of plan enrollees, and ultimately of taxpayers? So that's kind of, okay, I guess I got to get the skeet shooting right here. But so the next, the question really becomes, how do we align value assessments with the way patients, enrollees, and taxpayers actually perceive value in healthcare? Now, there are a couple things we have to do here. I mean, a lot of us have intuition about what's valuable regarding our health and our healthcare, but you got to take that intuition and transform it into something rigorous and quantifiable. And that's the job of economists. And I want to give you a couple of examples of how the innovation and the assessment of value can better align the way we assess value with the actual values, preferences, and needs of patients and plan enrollees. So one way in which this manifests is in thinking about how patients perceive uncertainty in clinical benefit. So this was referred to earlier as something called the value of hope, and I'll give you an example to explain the point. So imagine, or you don't have to imagine, this is a real example. So there's a drug for metastatic melanoma. Okay, this is the graph I'm putting up is from the New England Journal article that summarizes the clinical trial. And this particular drug added about 3.5 months of survival on average for patients in the trial. Typically, payers and economists focus on that number. We say, okay, well, the value of this drug is basically derived from the fact that it's adding 3.5 months of survival. However, there's something that's missing from that calculus, and that is that in this particular trial, the drug in question that added 3.5 months also gave patients a 1 in 5 chance of living for 4 years or more, whereas the comparator drug gave no such chance. So the question that you might ask is, are patients, I got to get this skill down. Are patients looking at the average effect, or are they thinking about this outside long-term possibility that they're going to be one of the lucky few that lives 4 years or more? We call this the value of hope, and it turns out we did a study of this, and we asked patients with metastatic cancer a question that amounted to, if you have 2 therapies in front of you and they both give you the same average survival, would you rather have the one that gives you a shot at long-term survival, even though it's going to increase your risk of dying prematurely? Or would you rather take the sure bet that's for sure going to give you a particular gain in survival? About 3/4 of the patients we surveyed preferred the risky gamble or the hopeful therapy, which says 2 things. First of all, that average values aren't all that patients care about. And second of all, there's diversity. Because remember that 25% of the patients liked the sure bet. So we have to do several things here. We have to align the way our value assessments match up with patients' actual values, preferences, and beliefs. And we have to allow for diversity, which is a point that Lou made nicely as well. So the second thing I want to talk about is another example here is how do patients think about the future and living to see the future? So Rena mentioned this in another context as the question of one reason you might want to live to see the future is because the future is about infinite possibilities. Now that's kind of an intuitive, squishy concept that we sort of understand, but the question is how do we make that rigorous and quantifiable and think about what's truly the benefit of living to see the future. So one thing that happens when you live to see the future is you also live to see future medical breakthroughs. HIV is a good example because back in the early 1990s, there was a drug called AZT, which wasn't a great drug. It added a few months of survival to people, but it was a fantastic drug if it happened to get people to live long enough to see the arrival of antiretroviral therapy that extended their lives by 10, 15, 20 years. That's option value. And the way you quantify it is you recognize that when people live for a long time on a new therapy, their survival curves over time improve because of other medical innovations. And when you account for the change over time in their survival curves, it's actually much more, it changes the calculus and the way we rank therapies. In particular, gene therapies, for instance, that have very long survival effects involve a lot of option value. In contrast, chemotherapies that add only a few months of survival don't have a lot of option value. So it should change the way we think about the relative ranking of drugs that have very long tail survival benefits and also drugs in highly innovative areas. The last thing I want to talk about is, remember I said that the people who pay for healthcare are patients and plan enrollees. And so far I haven't said anything about plan enrollees. So the question here is, how do enrollees and patients see the world differently? And is that a relevant issue? And I think it turns out, based on the research that we've been doing in this area, they do see the world differently, and it's important to think about value from the enrollee's perspective alongside the patient's perspective, because both contribute to the overall social value of a product. From an enrollee's standpoint, a medical technology is a little bit like an insurance policy. So I live in California. I have an earthquake insurance policy on my house, and I benefit from that policy even when there's no earthquake, because it provides protection for me, and it protects me from financial ruin in the event that my house is leveled by an earthquake. We don't say that it was a bad investment just because I didn't end up losing my house in an earthquake. Medical technology is similar. If I face a risk of developing Alzheimer's disease or cancer, or rheumatoid arthritis. That's a significant cost to me that could result in my financial ruin. It could cost me a lot of things in other ways as well. The arrival of a new medical technology for me as an enrollee is a little bit like that insurance policy because it protects me to an extent against the arrival of that new illness. So the value to the healthy enrollees is another ingredient that needs to be better aligned with value assessment. So in order to kind of wrap this up, I think the important point here is that if we care about the ultimate payers in healthcare, patients and enrollees, we need to continue to bring together innovations in the science of value assessment and then move into what Rena discussed as well, which is bring those accurate value assessments into the marketplace to ensure better innovation incentives. So with that, I'll close and look forward to the discussion.
Thank you, Darius. As Jeroen comes up, if there's any graph that's compelling for individuals, it's that one where you look at the immunotherapy with the 20% sustained survival versus the median in terms of how we make these assessments. And when we think of molecular diagnostics and other approaches, we may get closer to anticipating who those individuals are. But I think that's one that, as policy thought leaders, one needs to really focus on. Jeroen.
Thank you, Sam, and thank you, Health Affairs, for inviting me. So there's a recognition of the importance of value assessment. And in principle, value assessment boils down to comparing the benefits, the risks, and the cost of a medical technology relative to the alternative for a certain disease state. That's fairly uncontroversial. However, that's pretty much where it stops, because a key question is, how do we, in fact, combine and weigh the benefits, risks, and the costs? So how do we get an estimate of the actual value? For example, are we using a cost-effectiveness framework where we divide the differences in cost of the technology versus the alternative by the difference in the qualities? Or are we using an alternative approach like multi-criteria decision analysis that Lou referred to? So the key question is, how do we combine the benefits, risks, and the cost, but also whose benefits, risks, and costs? That's important. So there's a lot of controversy in value and estimates of value of a medical technology because it's unclear what kind of framework to use and what aspects of value to consider. But a more fundamental question is, how do we actually calculate these benefits, risks, and costs used for value assessment? So even if we know what kind of value framework to use, for example, if we say, okay, we are confident to use a cost per quality framework, still using the underlying benefits, risks, and costs of the competing medical technology is essential. And currently what we see in the literature, we see a wide range of value estimates or cost effectiveness estimates for the same technology purely as a function of the different ingredients that go into that value assessment. So in order to kind of reduce the controversy in value assessment, I think we first need to get an agreement how to get the math right. So how to calculate the benefits, risks, and costs. And once we're on the same page in that regard, we can start a discussion how to weigh these different aspects to come up with our ultimate estimate of value. So typically in value assessment, we have to rely on models. So there's hardly ever any empirical study that captures all the risks, benefits, and costs of the competing interventions of interest. So, and furthermore, the clinical studies that we typically have available are not really in line with the information we like to see to inform decision-making in the real world. So what we have to do is we need to rely on mathematical models or decision models. And what these models do is they integrate all the relevant data, all the relevant evidence, and provide estimates of the benefit, risks, and the costs that then can be used in our cost effectiveness analysis. So whereas the input of these models are typically based on systematic reviews and meta-analysis in a fairly transparent manner, the actual calculation of these model outputs based on the model inputs is much less transparent. And in many cases, these model choices have a big impact on the estimates of value, but unfortunately, the public doesn't have access to these underlying models. Yes, we can see what kind of data estimates within, but we have no idea what is the magic that happens to go from model input to output. And that's a kind of a big concern because it undermines the credibility of cost-effectiveness analysis or value assessment, but also it makes cost-effectiveness analysis pretty much irrelevant the moment a study is published, because cost effectiveness depends on the local setting, the type of patients you have, but also once new clinical evidence becomes available, this cost effectiveness analysis is no longer representative of the data. So what we want to have is an open source approach to model development to calculate the risks, the benefits, and the costs. And that helps us to improve not only transparency and the credibility, but also make cost effectiveness analysis or value assessment more relevant for the local decision makers. However, that's not the complete story, in my opinion. So what we need is actually a process to involve the different stakeholders to work together to develop so-called consensus-based model. One core model to calculate the risks, the benefits, and the costs that then can be used to inform the value assessment, whether it's a cost-effectiveness analysis purely based on cost per quality, or whether it's a cost-effectiveness analysis that incorporates additional aspects of value, like the value of hope or insurance value, or whether we want to use multi-criteria decision analysis. As long as we get a broad-based agreement, what's the underlying math, or how to get how to do the calculations for the risks, benefits, and costs, then a lot of the confusion and variability in estimates will most likely disappear. Okay, so this slide outlines kind of the concept. So we start off with a kind of open source, general, very flexible general model that captures all the scientific defensible approaches for cost effectiveness analysis to calculate the risks, benefits, and the costs. And we like to create a kind of community of researchers, scientists, and other stakeholders, in particular patients and providers, to really work together to reduce this variability in modeling approaches and come to a kind of consensus-based model that is arguably the best representation of current evidence and insights. And it does not mean that's only one model and that is fixed or set in time. It's really a dynamic model that over time will evolve based on new insights and when new clinical evidence becomes available. And also such a model does not limit us to work within a particular framework. So since we only focus on calculating the underlying risks, benefits, and costs, we can use this for a basic cost-effectiveness analysis, or we can use this for an MCDA, or whatever kind of framework you want to use to combine these different dimensions into an estimate of value. But at least we all have an agreement on how to calculate the underlying ingredients. So this slide gives an overview of an idea how for the process to achieve this. So we start with like releasing an open source model, release in the public domain all the source codes of these models. Then we solicitate stakeholder feedback, patients, providers, scientists, whoever is interested. And again, since it's an open source model, so anyone can make changes to these models and make modifications. And then after a certain period of time, we will have, say, a panel of experts, again, of these different stakeholders, who will review the modifications and the suggestions. And then by, for example, a Delphi panel, these recommendations or these suggestions can be incorporated into the actual model, and a new version can be released. And we can keep ongoing with this loop. So to summarize, in my opinion, we must attempt to reach agreement around the approach to value assessment, and a consensus-based process for developing open source models to calculate the benefits, risks, and costs that form the basis for the actual value assessment is the first step to finding common ground. And this opens up the opportunity to understand how alternative frameworks with different approaches to weighing these benefits, risks, and costs may come to different conclusions regarding value. Thank you very much.
Thank you, Jeroen. It's a great example of how, in a public domain, people can put in the multiple inputs, but then put their own perspective around it. Some will be very tight mathematical models, such as outcomes. Others, based on some of the more conceptual framework. But thank you. And now, from a patient perspective, because how the ultimate person who makes decisions, but not always the ultimate payer, I guess, of the process. But this is so vital that this all be brought together. So thank you. Thank you, Anna.
So I'm holding up the rear, and I'm sure everyone's eager to get to the discussion portion. So I'm going to go through my slides relatively quickly, and then I'm happy to expand on anything during the discussion. So a line that we use increasingly in our space is that patients are the ultimate stakeholder in healthcare. And I think, taking a step back and remembering that the whole point of all of this is to improve patient outcomes, and that patients really should be the sort of the hub where all of these value discussions sort of lead to and from. We talk a lot also about how no one knows a patient's disease better than the patient. So why does patient engagement matter? You won't know all of the different nuances of what a patient is going through unless you actually talk to them. We spend a lot of time talking to patients through surveys, focus groups, panels, and what we found is that particularly with rheumatoid arthritis, that there is a lot of nuance there. You could have two patients with seemingly identical clinical profiles, but a drug might work well in one patient and doesn't work at all for another. That on average, an RA patient has to try 2 or 3 different drugs before finding one that works for them. And that you may be on a therapy for a decade and it's working well for you, and then all of a sudden it stops. So these are all factors that need to be considered as we're talking about value. And of course, this seems obvious, but definitions of value should align with patient goals. So a policymaker might think that the appropriate quality measure for a patient recovering from knee replacement surgery is that they can walk a mile, when in reality, a patient may just want to be able to walk to the mailbox, and that's it. So again, talking to patients, asking them the question, what is your goal, is really critically important. Okay. Let's see. This does have a bit of a lag time. Okay, so what does value mean to a patient? This is a ridiculously large question that we can't really fully answer, but just some buckets that we've really distilled down, again, from talking to our own patient population. The ability to access healthcare. If you don't have health insurance, or you lack some sort of access, then all of this really doesn't matter. And it's not just do you have health insurance, it's also do you have transportation to get to your doctor's appointment or whatever it is. If you lack transportation, then maybe a treatment that requires you to get infusions every few weeks isn't the right one for you. So that needs to be really a part of the discussion as well. Ability to afford healthcare. This has been really a big question that a lot of different folks have been grappling with. But the affordability question is really important. We know that adherence to treatment drops off if a patient's out-of-pocket obligation is too high. And what is too high? It's different for everyone. But there are a number of studies that show how important this is. And again, if you go back to the whole point of this is to improve patient outcomes. Having a patient not be able to take their therapy because they can't afford it is really sort of the opposite of what we should be trying to accomplish. Specific quality of life goals, I've already covered that a little bit, so I won't go into great detail here, except to say that quality of life goals are not just about your sort of health goals, but also there's, the emotional aspect, there's the time trade-off, and all sorts of other contextual factors that we're starting to see incorporated more in value assessment frameworks, which we are grateful for. But I think even more grateful for the fact that a lot of those framework developers are recognizing that we're really just at the beginning of incorporating those kinds of factors, and that it's an area that needs to evolve. And again, that's where sort of patient engagement is really important. And then the last one, again, this is something that we really picked up and were, I don't want to say totally surprised by, but wasn't completely on our radar, but from talking to our patients, what we learned is, when they're trying to decide between treatment options, one of the things that they are most interested in knowing is, how did someone else like me respond on this therapy? So again, I think that's the sort of information that could be really impactful to policymakers. Okay, so how can patient groups engage in value discussions? I put on here first participating in ISPOR drug reviews because we actually went through one fairly recently. I would not recommend participating in an ISPOR drug review unless your drug is under review. But if it is really critically important to engage. And I see some folks in the audience who have been through this as well. And you do develop some battle scars from going through this process. But I'm happy to go into more detail on how we engaged with ISER in the discussion. But for now, I'll just say that through connecting ISER with patients and with some of this survey data that we had collected, we were able to sort of impart on them some of these nuances of patient disease, and certainly we saw some of that reflected in the final report. One quick example is the recognition that step therapy is not necessarily appropriate in all cases. Providing input on value assessment frameworks, I hope I've already made the case for why that's important, but it's something that we have been heavily involved in with various framework developers and will continue to do. Encouraging the development and use of patient registries, and that's not just encouraging patients to use patient registries, but it's encouraging people who are developing registries to use patients during the development of them, because for instance, if you are developing a patient registry and trying to figure out the best time to deploy it for a patient going through, say, a knee replacement, if you are using patients in the decision-making process, then you'll know that maybe 2 days after surgery isn't the best time to ask a patient to participate because they're focused on pain and recovery and things like that. And then developing protocols and tools to guide patients and external stakeholders in meaningful engagement. I think for a lot of us in the patient community, value assessment frameworks have really just become sort of a household term within the past couple of years. And people are still trying to figure out what does appropriate engagement look like. One thing that we're very involved in is actually developing protocols. And we actually created a position of Director of Patient Engagement last year so that we could kind of professionalize this as an organization. And then my last slide, which is definitely the meatiest, full of questions that, again, are really too big to answer here, but just kind of food for thought, that the biggest challenges moving forward, using the right metrics to measure value and really moving beyond QALYs. The fact that in a lot of QALY surveys, the way sort of they're packaged and asked now, there are cases in which conditions like inflammatory arthritis are weighted as, states worse than death is a problem. And then implementing value models without inappropriately restricting patient access. Issues around step therapy and prior authorization and these words that we hear more and more often are really critically important to us. And then the cost trade-off, we've heard a lot about that already today. I think that this is one of the biggest challenges going forward, and I think that perpetuity value conversation earlier really plays in here for our patient population, because if you're able to get a person with rheumatoid arthritis on early aggressive treatment, you might be preventing them from needing one or many joint replacements later in life, which obviously could have enormous impact to the patient and to society and the economics of all of that later on down the road. But when you're looking at upfront cost and who pays for it, and we're talking about expensive therapies and the fact that entities are really looking at 1 to 2 year budget windows in a lot of cases, how do you reconcile those things? And then sort of finding the best way to use value frameworks. There are a number of them out there. Can they live in harmony? Is there a market for all of those that are out there? And then how do they align with value payment models like MACRA and other just general value-based insurance design concepts? And then I guess just sort of last is just building consensus on the best ways to fully engage patients in value discussions. So how deeply should patients be utilized in these discussions? And what is the best way to do that? Can we build sort of standard operating procedures around this? And I think we're really at the cusp of kind of blowing that up in a good way, and that the next 5 years will look very different than the previous 5 years. And just going to end on that optimistic note. Thank you.
Thank you, Anna. I'm sort of find it intriguing that we've opened with Lou, who's led, a large group of international experts in value frameworks, and we've closed with Anna sort of saying there has to be much more vital engagement from a patient perspective, and in fact, it's right up there, moving beyond QALYs. Lou, the ISPOR task force that you led really appears to be endorsing the use of cost per QALY as metric that ISER uses and others. as a foundational element, as you've said, but we need to augment that. So from what you've heard and what your work on the task force, I wonder if you could give, and your long experience, your personal view on this in terms of how that gets truly augmented in a way that is meaningful, not just talking through these newer concepts that we've heard, but to put the patient front and center and these values of hope and the value of option and all of those others.
Yeah, thank you. No, it's really been a great presentations, and they sort of come together. And one thing I'd want to emphasize is that this cost per quality approach does really begin with the patient in terms of describing the disease before you estimate the impact on quality of life. So that is, there is a strong patient-centric approach to that. So the other thing, one of the members on our panel said, well, as a patient, I care about extending the length of my life and my quality of life. I mean, that's obvious. Okay, so what's the problem there? So that is kind of the core, the intrinsic value that Rena was talking about is there. I was just thinking that, 1980, I did a cost effectiveness analysis for CMS of heart transplantation. That was when I felt that I discovered the quality myself, because the survival was the 1 year. You could have 1 year survival. You could be in a hospital for 365 days, or you could be discharged after 30 days. Biostatisticians said they both had 1 year survival. I'm saying those are not the same outcomes. Okay, we need to adjust for the fact that they're out of the hospital. So, but that's 37 years ago, and it was kind of the obvious thing to do. This cost per quality is a starting point, but. I think I particularly like this idea of insurance value, and I think we can, we are working to develop methods to estimate these things, and I think we can do it. And I think, one of the other things when I was in my Project Hope days, I worked on something that CMS had a great term for called the discretionary adjustment factor, which is something each of us should have in life, But they had it as part of DRGs, and we would estimate every year. We did a survey of technologies emerging, and we would say, you need to put another 3% in the bucket because there are these other things that are coming that are cost increasing but quality enhancing. So it wasn't tailored to the individual technology, but it was an add-on to the system. And maybe some of these, as we start to work through these, some of them can be tailored finally to the technology, but others are add-ons. Okay. Now, I'll say two other things I want to say about our task force. We emphasize the patient-centric, but we also, as economists, we're looking at that level that, this plan level, the societal level, as taxpayers, we're all paying for this in the end, and so we need to, we need to keep that in mind. And I think, and there's the other point that's emphasized that people will say, if you're going to consider these things in healthcare, like some of these intangibles, you need to consider them in the alternative in education, other places we spend money. So it shouldn't be. We're automatically putting more money into healthcare because we're considering these things. No, we need to think about these other things when we're thinking about other educational investments, criminal justice, and other things. So need to keep that in mind, that we don't overlook that. So thank you.
Thank you. And by the way, other panel members, please weigh in on this. We really want a dialogue amongst all of you.
Well, I'll comment on the consideration of using insurance value in a more expanded quality framework. So I agree that survival curves could look different if you take into account these other competing risks, and that has a role to play in comparative effectiveness and cost effectiveness analysis in the future. I worry a little bit about incorporating more other elements of insurance value or these intangible values into the quality, because we're going away from this intrinsic value measure, which frankly is very useful in and of itself, particularly for making short-term decisions around coverage, reimbursement, access policy. And so I would say that yes, we can always build a better mousetrap, but we should, as a field, we should also focus on doing the thing that we can do the best we can, given that these decisions have to be made now, and we can't kick off these decisions for another 20 years while we do method development for all of that time. Period.
Yeah, I think, I'm largely in agreement with what's been said. So clearly, Lou's point is correct that quality in some ways is incredibly intuitive. It's the quality and quantity of life. We can argue, and we do argue a lot about how exactly to measure these things and how to implement them, and those arguments are never going to be fully resolved to anybody's satisfaction. And that's why we also need to think through, are there, as Rena pointed out, tractable ways to improve upon the quality and tractable ways to augment the framework? And so I think our goal is not simply to come up with lots of cool, clever, new aspects of value, but to come up with, to really align the way we measure value with patient goals, values, and beliefs, and also do it in a way that can be tractable. And I think, one of the concepts that I was emphasizing, I think can be measured in a reasonably tractable way. And I agree with Rena, though, that you shouldn't start to expand this into things that are so squishy that we can't get accurate measures.
Sure.
From the patient side, I think there's probably an inherent tension between kind of what patients want and what they expect from healthcare, and sort of how you reconcile that with, economic models and, insurance plan design, which is very important. And I think that's, it's a big question that folks have been trying to get at for a long time and will continue to. And I certainly don't disagree that, using the quality as maybe a starting point, because it is there and it exists, and how do you take some of these squishier factors and really sort of quantify that? I'm not sure the answer, but I am glad to know that it is a conversation sort of on the table, and that ISPOR and others are sort of looking at that. How do you refine, or how do you I don't know if it's moving beyond the quality completely, or just finding some sort of middle ground that helps to get at this tension.
Rena, you described sort of launch price and the components of launch price, highlighting its sort of the historical perspective that has as much impact as any of these frameworks. But at launch, we generally know the least about a drug in a way. We have incomplete information. We're not fully aware of how it's going to be used in the real world and other clinical settings. So how do you see the price evolving over time? And I know that the second panel will be discussing some of that, but these frameworks generally are promulgated at the time of launch, when you have price and you're building on either qualities or other elements. So is there a structure, a model, a concept that you would advance to sort of reframe this as time goes by and we get better experience with the value of the drug?
Yeah, thank you. I mean, so I agree. So there is this time component of these assessments that I think are challenging. The truth is that we have two sets of drugs that we have questions about their utility and what their place is in therapy, but also can we provide full access to them for all patients who may or may not benefit from them. And those are new, novel, breakthrough therapies for which there really is no true comparator, at least in the drug space, and for which, really understanding exactly how these drugs are going to be used and what their benefit is going to be and what their potential costs are really like of critical short-term interest. I think as a field, we do a very good job of producing estimates related to that, although even this week, we have learned that we have a new therapy, this gene therapy, Chimera, where the ISPOR assessment, which I think is going to be critical, frankly, to coverage decisions, both at the commercial payer level, but mostly at the state level, are not going to be available for another 8 months because of uncertainties related to when this drug is going to get launched and a whole bunch of other information that needs to go into the assessment as well. There's a second bucket of drugs, which are these older therapies for which the benefits or the costs have changed over time, either because something about the benefits and costs of that intrinsic drug has changed. We've learned more information about how it can be used or shouldn't be used, or the alternative set has changed. New therapies come into the market. We've learned new safety concerns about other alternatives as well. as a field, we don't really do a good job of making those type of assessments tractable and available to payers, but also to patients and physicians. There, I think we could do a better job. It's not really an issue of methods development. It's really an issue of having the infrastructure in place to actually do that in a timely manner.
Yeah, and if I can add to that, I think in this context, I really like, again, to advocate the open source models, because the dynamic nature of available evidence requires us that everyone who wants to update an analysis or needs to update analysis has the ability to do so without trying to reinvent the wheel and coming up with a different estimate purely because they used a different method.
Yes.
No, I'm glad you brought up the launch price issue, because people, you just forget that a lot of times at the launch we have 300 patients in a trial and we're negotiating price, and within 2 years we're going to have given it to 100,000 patients. And as a patient, you're frustrated that we don't get, and this is what PCORI was about, comparative effectiveness research. We don't have that. But at the same time, the payers are sophisticated consumers. They have pharmacists who can interpret the drug, and they're monitoring what's going on. There's an evolving clinical literature. So in some sense, you do have a kind of a dynamic readjustment process that goes on in our marketplace, even though it's probably more friendly than a place like the UK, where they actually use cost-effectiveness analysis. They will revisit the treatment guidelines for disease areas as a disease area, and they will use whatever cost-effectiveness information they have, and they'll promulgate new guidelines that have teeth, like this is the steps. Now, we do that in our marketplace. People do that in the interest of their own health plan. So it is dynamic. It's using that information. And so in some sense, the launch price may become irrelevant as new things enter. And we really do need to be doing that. But things are going on. There is the market does work to some degree for that.
Can I interrupt and say? Sure. So I agree. I think the market does evolve in these settings. But I'll tell you, we have there are some parts of medicine where the incentives are actually quite conflicted. So, for example, I think we would all agree that the advent of generic medicine launched into the market is a fantastic boon. These are safe and effective drugs that have been available in the U.S. market for a long time. Drug prices come down after generic entry occur. Fantastic, right? And yet, in infused and injected drugs, we see prices come down a little, but we don't see use expand for these therapies. And that's, I think, because the reimbursement incentives are not aligned with actually people using those therapies when they become cheaper. And so with a dynamic assessment that's assessing both benefits and costs over time, some of those financial incentives that kind of counteract the use of generics may actually help here.
Let me ask the panel one question before opening it up to all of you. And again, just 30-second responses, because we know, and you've all commented, that health technology assessment organizations exist in many European nations, Canada, Australia, but not in the US, where we really allow a dynamic market to evolve. But should we, in the US, have such an organization which actually may have regulatory and reimbursement authority? And I ask this because would it allow for actual greater investment in these value frameworks and technology assessment? So let's start, Anna, we can start from you. Should we have a national regulatory environment and framework for this?
Well, I guess my quick answer would be as long as patients are fully engaged in the process. I think it's an important question because I think we're lagging behind in a lot of ways here. I think it's something that as an organization, we would be open to, but really importantly, we would want to make sure that there is a really key role that is defined for how patients are part of that process.
Thank you. Others? We can go down the row toward me.
Sure, not sure if I truly can answer that question, but if we go down that path, I think it's important that it's very transparent. Like for example, even in NICE in the UK, they released these kind of assessment reports, and like 400-page reports, but still the question is it truly transparent? So if we go down that path of one organization, I think both in terms of process as well as methods, I like to advocate for full transparency to reduce any kind of controversy, what they produce.
I think, Sam, first of all, I think value assessment is critical. I think no one is disputing that point. And I think the work that Jeroen is leading at IVI is is a way forward for figuring out how to do this in an adaptable manner where the value assessment evolves over time with new evidence. I think that's critical as well. With respect to the question of whether there should be a single body, I worry about that for two reasons in the U.S. One is in a market setting, the perspectives on value are highly variable, and it's going to be difficult for a single agency to reflect all of those different perspectives. The second is just, if you think there's a lot of lobbying in healthcare now, imagine what happens if there's a single health technology assessment agency. I think it leads to what economists call rent-seeking behavior, and I would just prefer to see there be more competition in the development of those value frameworks and assessments.
I'm so happy to not be the only geek on this panel. So I agree with Darius. I think that rent sinking is real, and we've seen this throughout our healthcare, and actually we're seeing it now at the state level related to assessments of what we're going to invest in and what we're not going to invest in and who's going to decide. So what I would say instead is that we have a very robust set of methodologists who are very attuned to these issues throughout the academy. They know how to do this. They know how to do it well. We all speak to each other and have developed evidence-based guidelines, et cetera. So I think we can continue to invest in the academic production of these assessments. These academic assessments are not just academic exercises. They really do matter because they enter into discussions with payers, both public and private. So I think that can be encouraged. I'm very excited about the advent of ISPOR and other competing agencies that want to invest in this and take on the analytic task, but also, frankly, take on the political pressure of making these assessments and do the best they possibly can with the information they have. So I think some combination of private sector investment with investments in the academy that are focused on public health goals and other societal goals suffices.
Yeah, and this is my view, not ISPOR's view that I'm about to speak. So. Going back to Victor Fuchs and Alan Garber calling for a national HTA agency, I worked with the Office of Technology Assessment long ago. I think there is a fundamental informational market failure here that we don't, as I said, we don't produce information about how drugs work in the real world. And then also their cost effectiveness. So the market failed. Steve Pearson, I think, brilliantly realized there's a market failure. So he essentially started ISPOR, which is kind of privately supplied regulation, okay? The IVI is sort of another, so we're getting kind of a free market in this information, but are we spending enough as a society to do this? And we're underfunding PCORI, we're underfunding this HTA, and I'm not saying we should make a centralized decision like NICE, but there could be, or that we should all be done by government employees, but we need to put more money in the pot, probably through a centralized organization that produces information that everybody can use. Now, they may hire ISPOR to do something, or IVI to do something, or somebody else, but we need more money in this, and PCORI, in a sense, PCORI should have been allowed to look at cost effectiveness, not just effectiveness. So that sort of mechanism, but there's a fundamental market failure that this information is a public good, it's undersupplied in our free market, and we're all worse off because we don't know how medicines work 20 years out. Okay, so anyway, that's my position. But
no, thank you for that important comment. And where do you really feel on that? No, let's have some questions from the audience, please. How about, do we have a microphone or just, yes? Let's start with the third row here. Yes, sorry.
Thank you very much for a wonderful discussion. I'm just wondering, in the discussion of value frameworks, whether or not our emerging understanding of individual variation makes them yesterday's news. That is to say that without diagnostics, about which there was, with the exception of Dr. Nussbaum, there was no reference in this discussion, we can move forward and to take advantage of our understanding of individual variation. And I'm wondering if in that context, the frameworks might lock us into a one-size-fits-all paradigm, and whether or not you think there is value to investing in diagnostics so that we can know for whom these drugs are going to work, so that we don't just talk about the value of hope, but we can understand who's going to respond and who isn't.
Yeah, I think that's a really great insight, and I agree with you actually that value frameworks place a lot of constraints and make it harder for us to individualize assessments of value. And so I think it may be that we need to move on to some extent. And I would go even further and say it's about clinical diagnostics to address issues of how how treatment effects vary. It's also about preference diagnostics, understanding how people's preferences vary, how their resources vary, how their economic circumstances vary. That's a type of diagnostic, too, that affects the willingness to pay for medical care. And I think that's where we ought to be headed. So I really agree with that insight.
Yeah, and to build upon that, so I don't think that the framework would limit us. For example, if we look at cost-effectiveness framework, I think we should move towards something that's called individualized cost-effectiveness analysis that say that we truly capture all the heterogeneity in patient responses and patients' background risk to get an individual optimized value estimate.
I agree with that, and also, if you look at the work that Faster Cures and Avalier have done with their patient preference value framework that was released in the spring, they do talk about, sort of how do you use this? Do you use it at an individual patient level in shared decision making, which of course we endorse, and or how do you use it more at a population level and looking at economic models and things like that? And I think there is a role for both, and we're starting to sort of unlock that more.
And I think even if we look at a population level or a plan level, I think it's still important not just to simply look at the average, but truly capture the distribution of patients and their individual responses.
Thank you.
I got one comment too.
More comment, but let's get some
Okay,
questions, because
all right, okay.
that was an important question that could take up all the rest of our few minutes here. So let's...
Hi, Harry Quanter. I'm a pediatrician, pediatric rheumatologist from Richmond, Virginia. I think a couple things that I'd like for you all to comment. One is we're talking about patients, we're talking about drugs, we're talking about procedures. We're not talking about providers, especially cognitive providers, and there's sort of a squishy input into this whole system and what they provide. And I think the second thing is, as we're talking about cost or pricing, there's a difference between pricing at the official level and what the actual prices the payers and PBMs and everybody else are doing. And I share Dr. Conti's point about the chutzpah, but I think the chutzpah of the PBMs and the other managers of those pricing systems is even greater. And I'd like to hear how you figure that into the system.
Who wants to take that on?
Well, I want to make one comment. If you read our report, you'll see we're pretty careful to say this cost effectiveness, cost per quality works pretty well for medicines and some procedures, but it doesn't work well for some things like pediatric cases or cognitive therapies that there's a large part of the budget that we have to use other economic evaluation methods. So we're careful to say that. Okay, so I think that's a. But the discount, there's a lot of, our system is not as transparent, and there can be an argument for some intransparency, but it does create some problems. And I don't know, Rena, if you want to say anything on that.
I guess what I would say is simply that we don't price drugs based on their intrinsic value alone. We price drugs based on other elements of value as well, and that is the way our system is built. There is clear rent seeking in this system, not just from the manufacturer's perspective, but all the way down the line through the very complicated distribution channel, through the hospitals and physicians who make money off the prices of the drugs as well. So that is a topic for another day.
Okay, question here. Yes, please introduce yourself. And we won't get to all the questions, so we'll have a little bit of time between the break and the second panel to speak directly to
Deb Williams. I wanted to take a step back, Dr. Nussbaum and Anna, what you're saying, to take a step back to what we think about societal value, which is setting aside if we have any robust work on CRADA. But clearly what you're talking about, for example, we made a decision as a society to fund ACA, even though that meant more health spending. We made a decision as a society, so for example, the sequester falls much more heavily and has been devastating to the infrastructure. It's much more lightly on health. Now, as a breast cancer patient whose husband was just treated for kidney cancer, I'm kind of okay about hitting pothole once in a while, as long as everything else goes okay. So let's think about how do societal values get reflected downstream through our value frameworks?
Well, I think that's a really fundamental question and a great question. I think this is the question that in some ways economists are always struggling with and to bring into the science. And I think Lou made this point in a slightly different context about how in some sense all of the economic theory around qualities is striving to be reflective of the actual preferences and values of patients and people in society. And that's why I think we have to get values that align with everyone in society, patients, enrollees, and in a sense, and taxpayers. And that's sort of the sum total of everybody who's paying. And I agree with you. If the preferences of those people are accurately expressed in our value assessments, then we ought to follow those. That's absolutely right. And the challenge is to get them into the value assessment and then act on them.
And as you share your personal story, it seems that those preferences can either be done at a federal level or state level, and look how varied different viewpoints are in terms of how infrastructure and education and health spending are. Let's have one last question, and then we will take our break. Yes?
I'm Dr. Caroline Poplin. I'm a primary care physician. I'm also an attorney, and I've worked on several drug cases, including Celgene, which just settled for off-label pricing. I'm concerned that in the rest of healthcare and health insurance, we're talking about markets all the time. And in a free market, as you know, people don't pay for value. They pay for cost. In a perfectly competitive market, they pay for the cost to the manufacturer plus a limited profit that depends on what the company would have made in its next most profitable investment. And that's the price we should be looking at. That's the price they used in utility pricing when utilities were a natural monopoly. And I don't understand why the value was supposed to be consumer surplus, not drug company profits.
Sure, Darius and Rena. I think you each will comment here and then.
So, I think that it's certainly the case that in traditional goods markets, in a competitive goods markets, price is cost-driven. It's different with innovative goods, though, and this is with innovative goods, the key question is how do you balance two issues? There's access for consumers, and there's the incentives to encourage innovation. We know that if in a traditional goods market, all you care about is access. So that's why you have cost-driven pricing. That's the lowest sustainable price, and that's how you get the most consumers using the product. With innovation, you have to balance that against the need to encourage investments in research and development, and you need profits in order to do that. So kind of the fundamental conceptual question that comes out of economics is then, what's the next step? And the implication is that the right social policy is the one that rewards innovators with the value they're producing. And why is that useful? Because it encourages innovators to produce valuable innovations and not to produce non-valuable innovations. That's the reason why with innovative goods we want to link prices to value. But it's certainly we don't charge the value-based price for bananas, but that's because there's not an innovation consideration. But with iPhones.
And they're propped up by subsidies, but that's okay.
Fair enough. The bananas is a different conference, I guess.
So I'll take a stab at this question as well, which is, yes, that's right. In a competitive market, we pay for the incremental value and above the marginal cost of production. We don't really do that in this market because essentially what the monopolist price is here is some shorthand for the intrinsic value of the drug plus this option value, this perpetuity value, et cetera, added in. And there's been some, let's just say, behavioral pricing around these innovative drugs in the market that we've seen in the past 15 years as well. What we are struggling with, frankly, is that the price inflation of these drugs is frankly just outstripping wage growth, and it's also outstripping other forms of other measures of innovation or of productivity in our sector. And so we could think about trying to come up with ways of either restraining the quantity of this use or restraining its price. If we're going to come up with ways of restraining the price that we pay to get it closer down to that intrinsic value measure, then we still have to deal with innovation incentives. That's not going to go away. And so I am very interested in this idea that we have many tools in our toolbox to address that issue. We could reduce the price of these therapies down to more reasonable measures, but then we're going to have to give on other incentives related to incenting things that we think of as being socially valuable. So R&D incentives, other types of patent life incentives, quantity guarantees for stuff that we think is super valuable once it ultimately comes to the market. We did that with HIV already. We may see that we do that with Hep C. So the point is that if we want to provide access, we still have to address this innovation conundrum. And there are ways of doing it, but either we're going to do it through the pricing mechanism as we do now, or we're going to do it through something else, but we're going to have to do it.
So it's clear in closing is that the American people cherish innovation. We all do. We also cherish affordability and access. And I think you've seen from our distinguished panel that they have worked diligently to expand models and explore approaches that can give us a more balance of all three. So thank you all for participation. We're going to take a short break and reconvene.
The morning, I hope you agree, the morning conversation was outstanding. It did leave me with this sort of sinking feeling of, if this is so complex, so heterogeneous, so many different perspectives, how do you actually do anything with this? We could have a wonderful academic discussion about the challenges associated with alignment around an open source consensus-based value framework, but if we never actually achieve that, then we're sort of stuck with what we've got, and no one's thrilled with that. The good news is that, in fact, despite all of the complexity that we did want to focus on for the morning session, there's a lot of movement in this area, as with public policy or payment or anything like that. You have to work with what you have, even if it's imperfect. And so what we're going to spend some time talking about in this next session is sort of where do we go. You'll hear first from Peter Neumann, Director of the Center for the Evaluation of Value and Risk in Health at the Institute for Clinical Research and Health Policy Studies at Tufts Medical Center, and a professor of medicine at Tufts University School of Medicine. Also note that Peter is a member of our editorial board at Health Affairs. You'll hear from Alan Balch, Chief Executive Officer of the Patient Advocate Foundation and the National Patient Advocate Foundation. Michael Sherman, Senior Vice President and Chief Medical Officer of Harvard Pilgrim Healthcare, which is a nonprofit health plan serving 1.25 million members in Massachusetts, New Hampshire, Maine, and Connecticut. You may have seen on the agenda Kavita Patel from the Brookings Institution was to be here. She had a family emergency and cannot join us. I have asked Darius he will not be presenting in this panel since he had that opportunity. We don't want him to double dip, but because we are going to move into some Q&A, I think his perspective perspective on where we're going could be valuable as well. So none of our panelists have slides. This is intended to be more conversational, but it's my pleasure to introduce first to you Peter Neumann.
Well, thank you, Alan. Some of you know I was a co-chair of something called the second panel on cost effectiveness analysis, so I'm pleased to be on the second panel today. One day I'll make it to the first panel, but not today. I just have 3 questions I want to organize my remarks around. 1, what role should these value frameworks play? 2, what are some of the questions and concerns? And 3, where are these going? What role should they play? Well, I think we should all welcome them. It's healthy for our debate that we're having about price and value and affordability. They're coming from the private sector, which I think has some advantages and some downsides, but it's a sort of marketplace of ideas, as I think Lou said. They're evolving, they're improving. My colleague Josh Cohen and I wrote a piece a couple of weeks ago in Pharmacoeconomics. We said ISPOR, for example, is doing a number of things well, in our opinion. They're using cost per qualities. They're contracting with respected groups. They allow for conversations for contextual considerations, as they call them, things not in the quality. They have a budget impact analysis looking at affordability. They have a process which is, I think, admirably transparent and allowing for input to be sure it could be improved. They have emerged as a kind of nice, like American private sector body. And, I think they've done some things quite well. Same with some of the others. ASCO has now revised once, and they're revising again. So I think there's a lot of good things we should say. And as we think about who's using these, I think the private and perhaps public plans could look to them for information in a positive way. That said, I think there are definitely some questions and perhaps some concerns. We heard about some of the measurement ones that Lou mentioned. I won't go into those. I think there's a kind of legitimacy, accountability question that we should be asking at least. The fact that they're private groups means these are private citizens. Are they reflecting the value of enrollees in health insurance plans? Are they reflecting patients? We've been discussing it, but it's obviously important and the right question. There's a related question about perspective. My colleague Sachin Kamalbal and I had a piece last week in Health Affairs on the blog. A lot of ISPOR takes a health systems perspective. Understandably, one of the key audiences is private health plans. They're looking at health costs narrowly. They don't look at what we might call a societal perspective. The second panel on cost effectiveness recommends analysts do both. Do a health perspective. That's what payers seem to want, but also do a societal perspective, getting at some of the issues that Dr. Nussbaum talked about, issues around caregivers, issues around family impacts, issues around economic productivity impacts, spillover effects into other sectors. In fairness, ISPOR does allow for discussions of these things, but it's not reflected in their cost effectiveness calculation. Finally, where are these going? I think they're very likely here to stay. They're responding to a need in the marketplace. That need is not going away. To be sure, they will evolve. Perhaps other frameworks will enter. It's hard to know what impact they're having. Rena Conti said they're having a limited impact. That may be right. There have been some surveys of this by groups like Avalier and Exenda. It suggests that there's a high awareness of groups like ISPOR and ASCO perhaps too. One way to think about it is they're providing an input into a very complicated decision-making process on the part of these health plans. And they're providing, in a sense, you might say, ammunition to the people negotiating prices, people putting in formulary restrictions. Possibly, even plausibly, they're exerting some downward pressure on prices as ISPOR comes out with its reports suggesting that the prices are too high in the sense of being reflecting a value-based price. That is, the actual list prices, even negotiated prices, might be higher than the value-based price. I don't think we really know a lot about that. It probably varies a lot by health plan and by context. But I think we might plausibly say they're having some pressure like that in the marketplace. I think one key question, I know Dr. Sherman is going to get to this, can they inform innovative contracts? So I think about these value frameworks as providing information largely to the private marketplace. As I've been skeptical, by the way, about innovative contracts over the years in the sense that I think the hype has outpaced the reality. We have seen some very interesting experiments, some by Harvard Pilgrim and others. There's an interesting question about whether we've turned a corner, whether we'll see more of these in the future. I hope we do. I think these value frameworks can inform the prices in those contracts and perhaps the arrangement of those contracts. That's an important discussion to have. Finally, we can never look at these value frameworks in isolation as we think about their impacts on innovation. The impacts on innovation will reflect a lot of health system policies and incentives. And I think the value frameworks are adding to the discussion, but need to be seen in that larger context. So that's the end of my remarks, and I look forward to the discussion. Thank you.
Good morning again. If we keep up at this pace without the slide presentations, we're going to have a lot of time for discussion. So I'm one of those folks that I don't know if it's better or worse to not have slides, so I'll try to stay on point here, but agree with what Peter had to say. Wanted to reiterate and agree with much of what Ann had to say previously regarding the patient perspective. I'll try not to be too redundant. But just very quickly, I'm the CEO of the Patient Advocate Foundation, and we provide assistance to particularly low-income patients. So the average income of the patients that we serve is about $22,000 a year household, an average household size of 2, which puts most of them south of the 200% federal poverty level. So most of the comments I'm going to make when we get down to talking about patients are going to come from that perspective of patients who are not only low income, but many of these patients are newly diagnosed or actively in treatment. So about 80% of the patients we serve are within 1 year of diagnosis or within 1 year of treatment. So they've got the whole healthcare experience is decidedly fresh on their mind. If not, they're still in it. And they're dealing, because of the nature of their demographic status, they're dealing with the access and affordability issues in a way that's probably more acute than most of the United States, although it's certainly a problem that runs across the entire socioeconomic spectrum. So we were asked to focus a little bit up on what's next and maybe dig down a little deeper into thinking about the applications as it relates to the concepts of value and innovation. And we've talked a lot about value frameworks. I'm going to expand the universe a little bit here and then bring it back to a very specific point. And that is, so the playground, if you will, for some, and for some it's a battlefield around value, really is not just the value frameworks, but I think the application of the same concepts and the application of value is also relevant to decision support tools, specifically things like clinical pathways. Certainly the value frameworks are relevant here to the value conversation, the application of the concept of value and paying for value, and then just payment arrangements, as Peter was mentioning, value-based contracts. Again, so I'd argue that those are the three areas in which the value, a lot of the same arguments and a lot of the same discussion and food for thought that we've heard so far play out in all three of those arenas and more, of course. And then you think about policy challenges. I promise you I'm not going to go into details here, but you have some true policy challenges. You have issues related to HIPAA. You have issues related to kickback statutes and other regulatory and statutory environments. Then you have restrictions on cost effectiveness, particularly in the federally insured market. You do have some other areas that are actually not so much in the government domain, but actually in the private sphere, the non-government domain. You think about the IT, right? And so all the IT and the interoperability there that whole environment is largely driven by non-governmental actors. And then you have the patient-reported outcome environment, the quality measurement environment. Again, another place where you have a lot of non-governmental actors and entities setting policy. And so I'm going to come back to that point and focus most of my remarks there. But in my mind, a lot of these are ultimately come down to methodological challenges. And I think the penultimate one is really how do you we talk about value and innovation, and that's sort of the title here. The trick is how do you actually incorporate innovation into these value frameworks? Because if you don't, right, then how are you going to incentivize innovation? And the innovation that we're talking about has already been alluded to is really precision medicine, right, and the science of personalization and the sort of the genomics and the genetics of subpopulations. From a patient perspective, the personalization and the science of variation, which is essentially what genetics is really about patient preference and the variation as it relates to things like quality of life. And Ann alluded to some of them. I'll elaborate a little bit here. But the question becomes, it's really, from an economics perspective, it's a externalities versus internalities debate. So what are you actually going to build into your utility functions, into your quality measurements? There are some good ones already in there. Pain, certainly a universal one. Function, daily function, those types of things. But I think the ultimate tension is, there's this desire in a lot of the value framework methodology, as well as pathways and other places, is to try, and for good reason, to try to come up with something universal, right? So, have a utility factor that has the same measurement scale as, say, death. So everything's on a sort of integer scale. Well, the problem is that what matters to patients, right, and how to calculate that is going to vary significantly. And we're learning that more and more as we figure out more and more about the variation in not only the science of medicine, but also in patient preference. So I don't have time to go into the details, but we've kind of, through the work that we've, similar to what Ann mentioned with the Arthritis Foundation, we do quite a bit of survey work, both quantitative and qualitative in the patient population we serve. We've actually figured, kind of identified 5 or 6 fairly universal quality of life types of issues that patients routinely deal with that do significantly affect their ability to adhere to care, their ability to be satisfied with care, and that affect their quality of life. And we've talked, and I don't want to just reduce this whole thing to a quality of life conversation. We've already alluded to some of the challenges as it relates to, say, median survival versus the chance at an overall survival benefit. So I'm going to focus on the quality of life aspect here. Transportation is one that cuts across all disease areas. And there's significant, if you have 2 different treatment modalities, and one is going to vary significantly in the impact it's going to have on a family as it relates to transportation, that to me is a reasonable variation in a patient outcome upon which you should look at value. Employment is another one. So a patient's ability to stay at work, for those that are employed, this, obviously if you're retired, that's a different question, but your ability to maintain your employment, which obviously not only affects your income, but also for many people, and most of the market here is still commercially insured, so they get their insurance through their employer. If you can't stay at work, you're going to lose income, and you may lose your means by which you have access to the marketplace, the healthcare market through insurance. Side effects. We talked already about side effects. I think that's an obvious one, but we often, for some sort of a universal measurement function, we tend to go back to things like pain, which I don't want to minimize the importance of pain, but that's not necessarily the best universal measure. So for example, we just did a survey in partnership with 5 other nonprofits looking with prostate cancer patients, and only 3% of them reported pain as having a severe effect on their quality of life. The most significant impact on their quality of life was erectile dysfunction and sexual intimacy. And qualitatively, the biggest complaint that they had about measurement was, I don't want to be asked again about pain. Every time I go in, they're taking a pain score, and that's the least important thing to me. So I think when we think about side effects, the variation within certain patient populations, and I'm going to speak mostly to cancer because 70% of the patients we serve have cancer, but we serve a lot of other disease areas as well. I think understanding how different side effects and how they impact patients' lives, the variation in that is another reasonable basis upon which to create variation in the value frameworks and look at side effects differently. Another good one is breast cancer. Very few patients who we surveyed who are having infused chemotherapy for breast cancer, very few of them report pain as a significant factor. 50% of them report hair loss as the most severe impact on quality of life. So avoiding hospitals and ER admissions, that's another universal thing for patients. So patients really want to, no offense to great hospitals, great care in the hospitals, really do not like to be in the hospitals, don't like to be in ER. So those are all things that I think when we think about how to include patient preferences and how to think about the variation around that in value frameworks or pathways or value-based contracts, how to qualify those. And what I'll leave you with is I think the domain in which, when you think about value frameworks and the methodology around them, it's hard to all think about, it's a very esoteric world. It's hard for patients and economists and health providers to come together around that because you really have to have years of training in those methodologies. But the place I think where we all can work together, there's sort of a rising tide lifts all boats, is in the area of patient-reported outcomes and really understanding the science of patient preferences and then translating those patient-reported outcomes into quality measures because ultimately in the value-based payment world, what gets paid for and what gets incentivized is going to be what we can measure. And I would argue we really need, given what was said earlier about how little we know when a drug first comes to market or any technology comes to market about how it really works in the real world, patient-reported outcomes, I think, becomes the basis upon which we engage patients on an ongoing basis in measuring the outcomes associated with their care that matter to them. It becomes a data source that feeds into the inputs, the data inputs for all these different value frameworks. It is an area so desperately in need of innovation. So if we were to have a moonshot, I know this is it's not, we like to think about moonshot in the context of research and medical discovery, but I would argue for something really boring, which is a moonshot and tremendous innovation in the field of patient-reported outcomes as well, and the science of patient preference, because there we're still dealing with a very Byzantine and archaic world where we've got, it takes almost just as long to get a quality measure sort of approved and into the real world environment as it does to get a new drug approved. Yet we're not really, you see groups like FDA and others trying to rethink how we do clinical trial design and how we do the approval process with things like Fast Track Authority to really rethink the clinical trial design world. We need that same type of re-engineering and rethinking and innovative thinking as it relates to patient-reported outcomes. So with that, I'll leave you and thank you for the time and look forward to the discussion.
Well, thank you, and it is so good to be in front of all of you today. I was speaking with a group of pharmaceutical companies recently. It was a friendly discussion, and I survived it. But I was asked, why are you picking on us? And my response was, well, first of all, I don't think we are. But the whole rest of the care delivery system is moving toward paying for value. And as we heard in the first panel, and I think we all acknowledge, we're paying for volume, for number of pills or injections, et cetera, which is not a good formula for incentivizing outcomes. Let me also share some additional data. And again, Sam, I think, really got us off to a good start here talking about the spend on drugs. So I know there is a dialogue and maybe disagreement, but I know what we as a private, primarily commercial health plan spend on our commercial members. And I will tell you that in 2016, we spent 25%, 1 out of every $4 on drugs. Now, I will say in all fairness, and we all want to see more innovative treatments for ourselves and our families, with some of the things on the horizon, CAR T and gene therapy, et cetera, maybe that number should be higher. It's not about whether it is drugs or hospitals, looking at the entire mix and whether there are cost offsets and how it translates into premiums. So out of that, by the way, about 20% of the 25 is the pharmacy benefit piece and the other 5% medical benefit. The other thing I'll add is that actually understates the spend because we don't have visibility into what is spent in the hospital setting because of how we pay hospitals. So it's probably a few points higher. Another data point, the percent spent by the individual on drugs. In 2011, it was 34 cents out of every dollar spent on drugs. By 2015, it had fallen to 24%, and I was actually surprised, maybe I should not have been, that it fell further to 21.5% by 2016. And that's for a number of reasons, including the fact that we are consciously trying to protect the individual from these increases because otherwise they won't take the drugs, which is kind of the point, right? The other fact is that many of these new drugs are expensive, and with ACA maximum out-of-pockets and the like, they also help protect the member. The problem is that if the individual isn't paying for it, we all are, which for me as a health plan chief medical officer is problematic because we are getting tremendous pushback from the regulators, from employers, from everyone. And it gets back to some of the issues you heard about earlier from Rena, whether it is taking dollars away from other aspects, whether there are pay increases, whatever, but it's a real issue and we're seeing more pressure than ever. In the past, we've seen cost shifting and changes in plan design and narrow networks, et cetera. We're still seeing that, but we're running out of ways to move around dollars. So the fact is, if we see higher costs spent on drugs, it's going to translate into higher premiums, and the natives are growing restless. One other data point I'll give you, our year-over-year spend on specialty drugs, it went up most recently, and I track this on a monthly basis at 20%. So for the approximately 40 cents out of every dollar spent on drugs that's spent on specialty drugs, that's going up faster. Again, none of this is intrinsically good or bad, but it means that we have a challenge. So how are we going to manage that and balance access and affordability, which is what we spend a lot of our time thinking about? Well, we don't want to say no where drugs are needed. Our true north is to provide the kind of benefits and policies that we would want for members of our families, first and foremost. That's always a good moral compass. Would you be okay living with this policy if it were your family member? So, we are looking at different approaches, aggressive prior authorization, narrow formularies. And again, if you're trying to do that without limiting access for people who need it, you're limited in how far you can go. So we have been moving toward outcomes-based, performance-based pharmaceutical contracts, have about a dozen in place. I will say that I view these as experiments, as proofs of concept, as questions whether we can negotiate with pharma companies differently, et cetera. And I would agree with much of the dialogue, including what Dr. Neumann said earlier, that the hype is getting a bit ahead of the pilots. And I think part of that is just natural to the environment. People want to see results quickly, and if you think about it, for these agreements to show anything, you need to be on the drug long enough, whether it's 6 months, a year, 2 years, which are some of the time periods we have. And the other piece is many of the pharma companies have gone at risk to a limited degree because they're learning and dipping toes in the water. I do think that these are part of the toolkit. I don't think that they are the entire solution. Another really important point is a value-based agreement in itself doesn't guarantee anything. If we're paying for something that is fourfold what it should be, and we have a value-based agreement that may take it down to 20% less than that, that's, again, it's better than the alternative, but it doesn't really solve anything. And that's, I think, what a lot of people are picking up on and questioning. I will say that, I think we need, these are experiments, we need to build upon these. And if you ask where I think we need to go, it is thinking about some of the higher cost therapies, and that's really where the excitement and questions are. The higher cost therapies where there is uncertainty about the outcome. And I do think we are making great strides, and Edward Abraham spoke to this earlier, personalized medicine, where we'll be much more able to predict who will respond, where this will be less necessary. I don't think we need this for hepatitis C. I know that I hear anecdotally there have been outcomes-based agreements. We know that works between 95 and 100% of the time. That's not where we need this. We need this where there's high cost and uncertainty. That way, if you think about where we can be and where I'd like to be and how we can continue to afford everything, I would love to see more agreements for, again, some of these higher cost drugs where the pharma companies agree in return for coverage. They price it at some semblance of value, whether it is ICER's benchmark or something, if IVI does something, just something objective that says this is a fair price. And if they agree to go at risk for those cases where it's not effective, and again, maybe $500,000, $475 for the new CAR T therapy, maybe it is fair for people who respond and live for at least a certain period of time. It's probably not for someone who doesn't respond. And again, you could have the same discussion around many other therapies which don't work 100% of the time. And non-response needs not to be, we'll give you back 10% of the spend, but we'll give you back 90% of the spend, keeping something to cover the, the incremental marginal cost of delivering that therapy. And again, we haven't seen that yet. If you think about the cancer example that Darius mentioned, one way to overcome some of the hurdles around coverage is to agree on different types of payment models, whether it is an upfront cost with a rebate if people don't survive various periods of time, or maybe there's an upfront cost with a continued payment as long as people are alive. Again, these are not conceptually rocket science, but we haven't seen any takers. We also had a question about diagnostics, and I think that there's opportunity there as well. We're in one discussion with a diagnostics company, which I can't talk about because it's not complete, but the value proposition to them is that we would stop restricting coverage. They're guaranteeing that our cost will stay flat, that we will see cost offsets elsewhere, even if we see greater use of their therapeutic. And again, that's a great way to get a health plan to provide coverage. Some other points, I think that CAR T and gene therapy are going to call the question. In many cases, they are going to be life-changing, which means we want them available. We also need to be able to afford them without premiums going up to a point that people just can't afford insurance premiums anymore. Again, so these are begging for value-based agreements. I want to, say that a number of the companies around CAR T and gene therapy have gone proactively to ICER and said, please evaluate our therapy. And again, if they price it at a point similar to where ICER thinks they should be, and again, it could be another value framework organization, I think that there will be much broader receptivity. And there are a couple of examples, including a recent atopic dermatitis drug that was priced where ICER suggested versus what some thought the market might bear. And the other side of that grand bargain is that payers are generally supporting use of that drug. So there, I think, is some upside here for the pharma companies as well. I think if we can't figure this out, we're going to bump up against essentially a failure to be able to afford all of these, and we're going to be seeing more regulation. I'd much rather see all of us work together to come up with solutions and regulatory solutions. I do know that in most, if not all, of the states, there are multiple transparency bills intended to force pharma companies to demonstrate various aspects of their pricing strategy and cost structure. I think we do need more transparency, more visibility, but I kind of cringe at the thought of a multinational company having 50 different states, each with various requirements that require them to provide information, and I don't know that is a good solution. Before I conclude, I do want to make one or two other comments. First of all, the patient-reported outcome piece is really important. One of the challenges is it's hard to get that information. It's much easier to get information from claims or lab data. But there are changes that are being made. For example, EHR connectivity is improving. And our institute, the Harvard Pilgrim Healthcare Institute, which is a close partner of the FDA in managing the Sentinel project, which essentially looks at many data points from insurers across the country to look for evidence of post-marketing issues, safety issues. They recently developed an app which are actually putting in the public domain, which will allow individuals, for example, with arthritis or migraines or something which would be hard to measure the impact of by claims, to input information, and then, and this is the really interesting part, match it up with the claims data in a way that preserves privacy, et cetera. So I think tools like that will really expand our ability to measure what's important to patients, which is really critical. And then one final comment. The other reason I think this is important to pharma companies and why they should be embracing these results, these type of approaches, is that without them, they're going to face greater uncertainty. One of the challenges and some of the noise that we're facing is that we've seen some FDA approvals recently for a number of drugs that many view the data as being a little bit preliminary on. And again, I want to acknowledge the other side of that argument, which is without those drugs, patients would have to wait longer, and some of them may benefit. But the drugs tend to have limited data and limited efficacy and tend to be very costly, which means that payers are balking. So the reason this is a problem, think about the uncertainty for companies and investors. These companies now have no assurance that FDA approval translates into coverage by insurers, which for the most part has not really been an issue, but it is now. So I would love to see some sort of bargain where the FDA agrees to perhaps approve these drugs earlier than previously, but in return they need to be priced at some value framework type of benchmark, and there needs to be an agreement that they will receive that in cases where the endpoints are met and the endpoints that they themselves take to the FDA, and there needs to be a much, much smaller payment in cases where they are not effective. So thank you, and I look forward to the discussion.
I want to try to keep this on the practical side because there's still a lot of sort of theoretical questions that are bubbling up from the first session. I want to start with a question about how good these frameworks have to be useful. A lot of the move to value-based purchasing on the medical care side is a response to the notion that just paying for more isn't helpful. And although the measures of quality and the like may be imperfect, think the readmission penalty for hospitals, the notion is it's better than what we had before. So this, I think, follows a little bit on Mike's point about what will happen if we don't move in this direction. So my first question, I think I'd start here with you, Peter, is how good do we have to be better than the way we're pricing now to gain some yield from these value models?
Yeah, well, in a sense, it's a low bar, I think, because there's a lot of problems with what we do today. It's not very transparent, and it's all over the place. It's not pegged to estimates of value, of cost effectiveness, even of comparative effectiveness. So, I think the value frameworks are better than no value frameworks. There certainly are questions, and we should continue to improve them, and there are ways they've been improving, as I and others have pointed out. I don't know what else to say. We should shine a light on them, certainly. If you look at, for example, how did ASCO improve from ASCO 1.0, which was, I think, 2015, to 2.0, which was, I believe, 2016. They added quality of life as a dimension in their framework. They didn't have it before. That was a positive step. And, I think if you look at what ISPOR did, they changed the way they do the budget impact analysis and stepped away from calculating a sort of budget-based price. I think that was a positive step. They've improved their process over time. So, certainly we should work to improve them. But I think even in their earlier forms, they were better than the alternatives, and I think now they're quite a bit better.
Darius, since you didn't get an opening comment, maybe you can respond to this.
Sure. Well, I think I agree with what Peter said, and I think that if you think, so basically any progress would put us ahead of the game, it seems to me. Michael made the point that outcomes-based contracting is still very much in an experimental phase. I mean, just take the example of gene therapy. If we simply had a pricing construct that meant that patients who live longer end up paying more for the therapy, or their insurers end up paying more for the therapy, that would be a win. And it doesn't matter exactly how you assess the value of that. We can always improve value assessment, but we're so much farther ahead in assessing value than we are in paying for value.
I would agree with that. When I sit in our P&T committee meetings, and I chair our P&T, which makes a lot of decisions, as well as our tech assessment committee, we talk about price. And the problem is when there is no value assessment, you're talking about it in a vacuum. So $300,000, that sounds expensive. $700,000, wow, that's really expensive. And people are reacting to the numbers, but looking at the numbers without the value they provide is absurd. But without the assessment frameworks, that's what they have. Particularly with some of the gene therapies and others, they may have very high price tags, and they may be better value than other drugs that are priced half as much. Again, we need new approaches. It's a little simpler, for example, if you look at hemophilia, and you're paying a large amount maybe over time, but you're not paying for hemophilia drugs, which are frequently 6 figures a year for most patients on them. Different construct if you're paying for a drug that helps preserve vision. Again, it's no less important. It's a little more complicated to figure that out. There are mechanisms. So I've spoken with ISPOR, and I think that's going to be important in helping inform our decisions.
Yeah, I do think there's some advantage to moving forward. I mean, the mother of invention is necessity. So to the extent that we push forward with we're not ready to pay for value. We don't really have a good way to define value. We don't understand yet enough about how patients define value and how that varies and why to truly pay for value. That doesn't mean we shouldn't not shift, because in forcing that shift, you force those conversations. It's a very disruptive approach, but I think that's a good thing. It creates first adopters, it creates intervention in the marketplace. So I do think some of these are good enough to be useful. It just depends on how we're trying to deploy them and in what way. So I think because the science isn't there, we talk about the science of innovation and personalized medicine, how disruptive that has been. That disruption has not followed suit in the reimbursement environment, in the value framework environment. We're still using very old methodologies, very old technology, where the technology is changing so rapidly on the scientific side. We haven't changed our other institutions to sort of match. And I think that's the challenge before us. And we as patient advocacy groups, I think, are part of that disruption. We're trying now more than ever to understand from our patients what are patient preferences, how do those vary, to bring that science of patient preference to the marketplace, so that and I think the value framework developers and the pathway measure developers, they're willing to listen. I don't think there's this sort of iron wall. I mean, I think at first they're like, what do we do with these patients? But I know IVI, I know ISPOR, and I know ASCO and NCCN and others are very much trying to engage patients and figure out what does that mean. They all have patient engagement strategies and patient engagement platforms platforms. So I think as long as we develop these things in collaboration, and again with an eye towards the ultimate consumer in the marketplace, which I would argue is the patient, that we will come out better with what we have now. But we've got to push the envelope, and we really have to push the envelope around what I already alluded to, which is really understanding how to incorporate patient-reported outcomes and incorporate those in more meaningful ways, in ways that matter to patients, into these frameworks. And so until we've done that, I would argue that we can't move to, I don't want to say let's not do anything, but I think it's just on a scale of how quickly do we incorporate these, how quickly do we use these as the basis for formulary restrictions or other things. So and I don't have the answer to that, so it's sort of I would argue for a balancing act and some leeway and some sympathy, if you will, for the fact that we still have a long way to go in really understanding what is value and applying that concept, at least in an environment like the US. I know Europe is much farther ahead of us, but to the question you posed earlier about should we have sort of a NICE in the US, well, give me government-run healthcare and I will take NICE. But in the absence of that, I think it's a little hard to sort of appoint one health technology assessment for the entire population. I think that's sort of what we have now with some competing ideas and marketplaces is probably more apropos for our current healthcare environment here in the US.
I was struck in the morning's discussion about this notion that you pay differently for innovation than for a normal good because you have to reward the innovation and create incentives for innovation. So the question I have is, that's great, makes a lot of sense, but the people making the payment decisions aren't necessarily thinking, I want to pay more than I would otherwise because I'm supporting innovation. It's sort of the free rider problem. Who should absorb the cost of the innovation, the excess cost? So I'm curious whether the value frameworks do help us with this question of allocation, or if they're sort of agnostic about that, they're just giving us a value, and then it's for all the different actors to duke it out over who should bear that cost. I could see a challenge here where on the one hand, we do a great job figuring out value, but none of the payers who are making their micro decisions want to build that into their price, and then we're sort of stuck. So how do we use this in the real world?
Yeah, I think that is a really complicated question. And first, I do think the value frameworks are primarily agnostic, which is fine. But the way I reconcile the moving parts is I see that as one piece that should inform pricing decisions. Another piece, for example, is, and this is, again, more the MBA side of my brain speaking here, is that to attract capital to risky ventures, including biotech and others, and related types of industries where there's a high failure rate, there needs to be a high enough risk-adjusted return. And again, if the risk is here, the return needs to be there. So we need to also think about that as well. And then another piece here is kind of that question, particularly since, unlike economists, we in healthcare don't assume that a dollar spent on one thing is a dollar spent, not spent on something else. We just assume we'll pay for everything. But since well, we do, unlike other countries. But the point here is when you have something like hepatitis C, which has been talked about a great deal and where there still are restrictions in some organizations. One of the issues there, you had the initial value assessment framework question, whether it was too high. And again, I don't want to rehash that other than to agree that with some of the recent competitive changes and discounts, it probably is fairly priced. But there were two issues there, one of which was the surprise of the system. And if you're a health plan and you're trying to price into next year, and if you're a not-for-profit and you're trying to make a 1 or 2% margin, and you have a new expense that is 2% of your spend or more, and you didn't know about that, you have a problem, and it forces decisions that might not otherwise be made. So part of that is a visibility issue. But the bigger issue with Hep C, and this is another lens on what is a fair price, is what is a fair market size. So with Hep C, everyone was surprised by the cost, the $84,000 initially. The main reason wasn't that we don't see a lot of sequelae from untreated hepatitis C, it's because in this country there are estimated to be between 4 and 5 million Americans with hep C, and we've never seen a drug for that population size that was priced at that level. So when you multiply the two together and you come up with that market size, I think a lot of individuals felt that was a bit egregious, given that those were dollars that cannot be spent on other treatments.
Darius and then Peter.
So yeah, this is a really fundamental question, and I think it's where we get into the policy questions and some of the policy weeds. I mean, the good news is that there are working markets for innovative goods where this is fine. The bad news is that they're all outside healthcare. So think about, so Apple has announced they're going to sell their new iPhone X for $1,000. Will they get it? Who knows? But they'll get it if consumers think it's worth $1,000, and they won't get it if consumers don't think it's worth $1,000. And ultimately, Apple's going to get paid for the value of its phone, and that is properly incentivizing them to invest in the R&D on the iPhone. So now let's turn to healthcare. What's the issue? Well, the problem is there's all this, there's separation between patients, consumers, and the decision. And some of that's intrinsic to the need for third-party payment. Some of it isn't intrinsic, though. I mean, I think one of the downsides of the employer-based health insurance system, which is an artifact of our tax regulation, is that consumers and patients get pushed even one more level beyond the healthcare purchase decision or the health insurance purchase decision. So I think that's a problem that we could make progress on. I think fundamentally, though, bringing enrollees and patients closer to health insurance and healthcare decisions will ultimately help us, with the caveat that it's not the right strategy to continually expose patients to more financial risk, because that's the whole reason we have insurance in the first place. So I think those two things need to be balanced here from a policy standpoint.
And I'd agree with what's said. I'd just add to your point. You could think of the frameworks, for example, ISPOR, as informing, they may inform a lot of people, but informing payer decisions at allocating health budgets. And so that's fine. The problem is there's things that are not in the health budgets, and nobody has that perspective. Again, the second panel that I was a part of talks about the fact that there's a kind of a public interest perspective, if you will, a societal perspective that would capture, you treat the depression, you help the families. You treat the depression, people go back to work, you help society. And we can measure those, however imperfectly, and we can capture those. The problem is nobody pays for those. So what do we do? Well, one possible solution is you have a public HTA, to get back to the first panel's discussion, have a public HTA and mandate that they take this broad perspective and put that information out there. Now, that would not be popular with a lot of people, I understand. And ironically, some of the same people who are advocating for these broad societal perspectives, frankly, industry, wouldn't like the idea of a public HTA taking that perspective. But, short of that, we're going to have this conundrum where nobody takes this broad perspective. We can measure it, we can put it out there, and, and ISPOR does have discussions that get at it, but it's not in anybody's budget.
Open it up to a few questions. Right here, wait for the microphone, please, since we're recording.
Hi, John Clymer with the National Forum for Heart Disease and Stroke Prevention. Peter, your comment just a second ago really jumped out at me. Your reference to the endogenous costs that aren't captured and the value from a societal perspective. I think in addition to manufacturers, those of us in the public health arena would have a lot of interest in identifying those costs, quantifying them, and factoring those into the value equation as well. And my question is, why can't those be identified and quantified and factored in?
Yeah. Well, again, they can be. To be sure, there are measurement issues. It's harder to measure those things. We typically don't collect data in clinical trials on such issues as family, caregiver effects, and productivity and spillovers into other sectors. But I should mention CDC, and Dave Stratton and I were just talking a little bit. CDC does put out economic evaluations for new vaccines. They do, as far as I know, include some of these broader considerations. Productivity and so forth, and there's there's a conceptual debate about how you do that and such, but you can, and they do, and one can. And again, in the second panel, we say elected officials should take this perspective. Elected officials are not in charge of health budgets. at least, at the federal level, whatever, a certain state level of elected officials, they're in charge of all budgets, education, health, housing, and so forth. They're thinking about broad allocation of resources. So somebody should be thinking about this. And again, I think it's great that CDC is putting out some of this information. A lot of this is done through the Advisory Committee on Immunization Practices, the ACIP. But if you look at published studies, most do not include these societal factors. And again, ICER in its cost effectiveness ratios does not. They allow for separate discussions of it.
Yeah, I mean, I think that's the great challenge, and that's the new frontier that we're on, is how do we, I think the data is out there, or they have been for a while, but never really been a concerted and organized effort to figure out how to capture that in a way that can be incorporated into the value frameworks, because there's been a disconnect between the economics of cost-effectiveness research and the health economist world. I mean, frankly, they're used to doing things the way they've always done them, right? So their models and their methodologies are pretty well established, and sort of there's this scientific and institutional rigor around those. So it's hard to change those methodologies, just like it's hard to change the way FDA does clinical drug trial approval. So I think what we're trying to do now is, and I think where there's receptivity is in those old institutional frameworks where they've gotten used to doing things a certain way. Now there's, I guess, the risk inherent in the work that they're doing is so much greater now, because there's this specter, or depending on your view, hope or specter of some sort of HTA body coming in and really being used as the basis for setting formulary, for at the national level or at the regional level, the plan level. And I think that sort of ups the ante in terms of how important now, at least in the U.S., these sort of value frameworks are, because they really can have a significant impact on patient access and on innovation as well. So I think that's the challenge, is how do we really capture the data we need to capture in a way that can, and how do we look at the current methodologies and think about how can they be adapted so that we can better marry up, what we know and what we're learning about patient preferences and how that varies, and what needs to be incorporated into the utility functions, if you will, for equality if we're going to use that as the paradigm for sort of making these benchmarks. And I think the other tension is, to what extent is the goal here to sort of predetermine value to the population before, as a drug comes to market, or as a, and I do want to go beyond drug a little bit here. It was already mentioned before, and we're focused on that. And I can make a comment to explain why if need be, but I think the healthcare is expensive across the system, whether it's surgery, radiology, hospital admissions, ER, doctor's visits, drugs, it's all expensive, and there's a lack of value in pricing sort of sense at all levels. If you ever looked at a hospital master charge, it's like, why is that $20,000? It's like, it's an imaginary list price, just like, rarely is the list price when you look at a drug the actual price that anybody pays. But that point aside, I think the tension is, do we predetermine, do we sort of set some public bar and say this is value, and the price, if the price is set here, then this many people should get access to it? Or, and these are not mutually exclusive, or do you engineer some sort of process at the point of decision, which is where most consumerism happens, is transactional. You're making value-based decisions at the point of purchase, so to speak. If we're going to try to, and I think there's opportunity there to actually use value as a concept to inform decision-making at the point of transaction, that's another place where, if we're going to do that, you start to get to more of a consumer type of market, which Darius was alluding to, which is, all right, I've got two options here for treatment. They have decidedly different, they may have decidedly different benefits, cost, toxicity profiles. How is I, as a consumer, as a patient, and with my family and caregivers, make a decision about which one may be better than another? Now, maybe somebody, in some cases, we're trying to take that decision completely off the table by making a public decision and say, you're not even going to have that choice. We're not even going to let you think about that as an option. We're going to give you one option. Or we're going to give you a couple options, and then we're going to give you the information you need to make a difference, whether transportation, or whether hair loss versus neutropenia, or whether 3 months at median survival versus 20% 5-year survival. Is that are those the bases upon which you want to make a decision?
We're reaching the end of our morning. I'm going to close with a conundrum, an observation, and an expression of appreciation. So I'm going to start with the conundrum. Forgive me, I've been scribbling this down. It's going to take me a minute, but I hope it's helpful. We've talked a lot about patient-reported outcomes and incorporating patients into the discussion, and I was really struck by the number of times there's been reference to the slide that was put up where you have a new drug that moves the, I believe it was 48-month survival from 0 to 20%. So imagine, 100 people, now 20 of them have extended survival relative to the prior drug. And we talked about the value of hope. And then I had this thought. I said, what if we came up with a diagnostic so we knew which of out of that 100, so we knew which of those 20 were. That would be a tremendous advancement. We would not subject the other 80 people to all of the negative side effects. We would also take away their hope. And if the hope value in some sense exceeds the value of other things, we might actually see a diminution in societal value as a result of this diagnostic advance. That seems counterintuitive to me. And then I thought of one other thing just because I couldn't stop. What if everyone in the population had the screener so they knew whether they were in the 80 or the 20? Then the 80% of the population that knows that they would never respond to this new treatment would have zero value to include in their premium unless they had a loved one or a friend. It would be nice to think people have some social value, but from a personal perspective, there would be zero value to them of inclusion of that drug. That would also reduce the social valuation of this drug. So I think we just have to be careful as we think about all of these inputs, that we don't put ourselves in some sort of an odd box where clear clinical advances turn into manipulation of the value formula that could make the value look worse. That's the conundrum. The observation I owe to Michael Millinson, who pointed out the quotation from Oscar Wilde, appropriate as we are here, that a cynic is someone who knows the price of everything and the value of nothing. Let us hope that we have fewer cynics in this room than we had this morning, because we have moved the discussion of drugs from price and other interventions from price to value. And finally, my appreciation to the panel for their comments this morning as well, and to the Innovation and Value Initiative for making the day's event possible, to you for attendance. Please join me in thanking our last panel, and thank you for being here today.